In order to make a dent in cancer health equity, you need to have multi-level approach, including assessing what the problem is, implementing research that is small but additive, and also focusing on the areas of the most unmet need.
That's Dr. Adam Kittai from the Ohio State University Comprehensive Cancer Center. He'll be back later in the show. Today, equitable care for all patients with chronic lymphocytic leukemia. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Chronic lymphocytic leukemia, or CLL, is rare compared to other cancers, which means community care teams may not see it very often. That, among other barriers, impacts care equity. Our guest today explains ongoing research to examine these disparities. Dr. Adam Kittai is a hematologist and assistant professor at the Ohio State University Comprehensive Cancer Center, the James.
So I trained at the Oregon Health and Science University in Portland, Oregon for my hematology and oncology fellowship, where I specialized in research for lymphoma and CLL, really working on retrospective research, defining prognostic variables that predict survival in the era of our new therapies. I also worked on clinical trials while there, and that's what ultimately led me to my current position at The Ohio State University, where I'm part of the CLL group, where I only see patients with CLL and I only do research on CLL. I continue to do work looking at prognostic variables that predict survival using our novel therapies, and I'm also heavily involved in developing cellular therapies for the treatment of CLL. And recently, I've gotten involved in doing population-based research, which was a natural extension of the research I had done previously, looking at the prognostic variables that predict survival, just on a larger scale. And recently, I focused on determining whether or not there are racial inequities that lead to worse survival for minority patients with CLL.
Dr. Kittai, you recently presented some abstracts at ASCO on racial disparities in CLL care. Can you tell us a bit about those and what you found?
So there were two main abstracts that were presented at the American Society of Clinical Oncology that focused on racial disparities in CLL. One was the abstract that we did here at The Ohio State University that is now published in Blood Advances that used the SEER analysis, which is a national registry made up of 17 different places in the United States that basically pulls information from patients. And the other analysis was done at the University of Utah that looked at the National Institutes of Health's database that pulled about 90,000 patients and also looked at racial disparities that predict survival for patients with CLL. And we both found very similar findings.
What did you find at Ohio State?
So the SEER database is data that's captured through the nation from 17 different localities that is more heavily urban, but it is found to be a good representation of the United States as a whole. And so there are a lot of papers out there that look at various different health aspects of the United States using the SEER registry. So this is a common registry that people use to do research in. So what we wanted to look at was whether or not minority patients live shorter lives with CLL than patients who are white. And we were able to find 50,000 CLL patients with CLL in this registry. About 10% of those patients were Black, which is what has been seen in previous studies. The last time that anyone had really looked at the SEER database looking at this question was published back in 2014. And in that study, they did find that Black patients did have less overall survival or a less overall survival time than patients who were white. But we've had a lot of new treatments that have been approved since 2014. And we wanted to see whether or not racial disparities continue to exist in the era of these novel therapies, given that we use these novel therapies more than we do chemotherapy for the treatment of CLL. And what we found was that Black patients had shorter survival than white patients, even in the era of the new therapy starting in 2014, and even when we accounted for lower socioeconomic status. And this was also confirmed even when accounting for age as well as date of diagnosis. And so this study doesn't tell us why these disparities exist. It does tell us that even patients who are of higher economic status have worse outcomes if they are Black than they are white, which is interesting.
Dr. Kittai, what are some of the issues that providers face helping these patients access care?
So, as much as we like to think we have a broad, diverse group of patients that see us at academic centers, that is most likely not the case. And a lot of us believe, and there's some other data looking at this in other hematologic malignancies, that we are not seeing a diverse enough population at academic centers that allows for patients who are minorities to enroll onto clinical trials that eventually prove improved overall survival. Additionally, if people are not being seen at academic centers, they may not get as good of care. That's not entirely true. Local providers can certainly give superb care, but there has been some data presented previously in the 2010s out of a US group and the Canadian group that showed that patients with CLL who are seen at academic centers do better than patients who are not referred to academic centers that specialize in CLL care. And so I think that it really is an access issue where, for whatever reason, minority patients are not being seen at academic centers at an equal rate as white patients.
How do we address these barriers with our patients?
So I think it's really multifaceted, right? I think that if you're a minority patient who are more likely to be of a lower socioeconomic status, who may not have as much resources as a person who comes from a higher socioeconomic status, that can lead to multiple reasons why they might have difficulty with access to care. So, for instance, academic centers are typically located within an urban center, so it might be difficult for somebody who lives in a rural space to even drive to an urban center. It costs money to drive, it costs money to park at the urban center. So these are all small barriers, but they are additive over time. In addition, it takes time to take off work, right? So patients who are hourly workers may not be able to afford to take off work in order to go seek a second opinion that may be far away for them. And even though they may sound like small issues, are additive and lead to this issue with access to care. One thing that is good for access to the care is the internet. So there are some programs through the CLL Society, along with the Lymphoma Research Foundation and the Leukemia Lymphoma Society, where you can access consults with experts who are experts in the disease that you're looking at, specifically in CLL and the CLL Society. So I do urge patients to visit those websites and take a look if there's an ability to get a second opinion from an academic doctor, just to make sure that you're receiving the care that you deserve.
Tell us a bit about your team's work to engage underrepresented patients with CLL.
So this is not a CLL specific answer, but I am the leukemia research liaison to the Ohio State University's Center for Cancer Health Equity. And so what this group is a group of doctors, providers, statisticians, various other people led by Electra Pesquet. And the goal is to reach out to rural areas in Ohio to allow them to have improved access to care at the Ohio State University. Underneath this purview, there's a lot of research that's done specifically with screening for cancers, as well as various other goals that we hope to achieve. In addition to this specific group that I am a part of, my own group that does research involves an epidemiologist, Jay Fisher, along with a statistician, Ying Wang. And these two people are really crucial. And in order to do work, especially population-based work, you need a statistician that is skilled in looking at large data and an epidemiologist that is skilled at interpreting this large data, as well as being able to pull the data from various different databases. And so I think that in order to make a dent in cancer health equity, you need to have multi-level approach, including assessing what the problem is, implementing research that is small but additive, and also focusing on the areas of the most unmet need. And specifically in Ohio, that's Appalachia, but that is not the same across the United States. And ultimately, as I said, I think that academic centers should have a group that is specifically charged with this, like OSU does, in order to make a dent in improvements in cancer health equity.
What are some systemic changes, do you think, that need to happen to improve racial disparities in care for CLL?
So I think broadly, thinking about how to improve racial disparities broadly is by allowing for low-cost health insurance for patients who can't afford it. So I'm not a political expert on this or policy expert, and I think that most doctors would agree that patients who do not have health insurance do not seek health care, and patients who are minorities or who have lower socioeconomic status are particularly affected by this when our health insurance is directly linked to our employment. And so I'm not going to go into the weeds on the policy with allowing for universal health care, but I think that would broadly improve racial disparities.
Dr. Kittai, going back to the diversity of our clinical trials, what needs to be done there?
Another very specific thing that we can do as cancer clinical trialists is really focus on broadening the diversity of our clinical trials. So there was one specific paper that was recently published in JCO that looked at various hematologic malignancies and how well we did at enrolling a diverse group of patients to the trials that led to drug approvals. And then when they looked at how many Black patients enrolled to the trials that led to drug approvals in CLL over the last few years, they found that it was only around 1% of the population was made up of Black patients. Whereas I stated earlier, when we looked at the SEER database, about 10% of patients are Black with CLL. And so that's a huge difference. And so I think we really need to think about how we're enrolling patients to clinical trials, how we can improve our diversity in enrolling to clinical trials. And it matters too, because if we're not enrolling a diverse group of patients who are representative of the population, can we truly say that the clinical intervention that's described in our clinical trials will work for our minority patients if there's no minority patients in the trial?
Last question. What do we need to keep in mind when we're treating these patients?
I know I'm focusing on population-based research, broad stroke research, but really it comes down to the patient sitting in front of you. And if we start to focus on the barriers that our patients experience, one patient at a time, we should be able to make a difference. So even when you don't think you can make a difference, you can if you focus on each patient in front of you and work on solving those barriers that our patients have and reasons why they may not be getting equitable care as opposed to their cohorts.
You can check out the resources in the show notes for more information on our guests' research and ensuring equitable access to care for patients with CLL. This episode was made possible by support from AstraZeneca, Pharmacyclics, and Janssen Oncology. Until next time, for the Cancer Buzz team, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.